I'd now like to welcome Clarissa Gracia, who is a faculty member at the University of Pennsylvania in the Department of Reproductive Endocrinology, and she is a rising star in clinical investigation, primarily trying to come up with some of the data on the gonadotoxicities of a variety of treatments and on human ovarian reserve. Clarissa, it's a pleasure to welcome you.
Thank you so much. It's a pleasure to be here today. Every year we get up here and talk about the progress that we've made, and I have to say that I'm always impressed with everybody's presentations, how much is being done through this consortium, and what a pleasure it's been to be here. I don't know if you can hear me okay now. Okay, so today I will talk a little bit about my work on the impact of cancer therapies on ovarian reserve, but I also want to talk about some of the clinical initiatives that we have implemented at Penn, and also some collaborative work that we've done with other institutions within the NPC, and I think that's been one of the real strengths of this consortium. So as you know, there have been pretty dramatic improvements in fertility preservation technologies, particularly in the area of oocyte cryopreservation, as well as ovarian tissue cryopreservation. And to date, on my count, there have been approximately 14 live births that have occurred from transplanting previously thawed ovarian tissue. And so while these technological advances really represent a huge stride forward and offer hope to cancer patients who are facing fertility-threatening procedures, they still are limited and pose some risk. They delay cancer therapies anywhere from days to weeks, require invasive surgical procedures, and also are quite costly. There are also considerable ethical questions, particularly when we're talking about taking care of children. So we really need to figure out how to target these fertility preservation technologies to those who are at highest risk. And right now, it's still difficult to predict with accuracy the reproductive horizon for cancer patients. Those who receive what we would consider low-dose therapies sometimes end up having acute and long-term premature ovarian failure, and others who receive more toxic therapies sometimes have no trouble conceiving in the future. So we really need to get a better understanding of the reproductive horizon for cancer patients. In addition, we really need to understand what factors determine the degree and duration of ovarian dysfunction in these patients, to help us understand who we should target. And we need to recognize that even if technological advancements occur so that ovarian tissue cryopreservation becomes kind of the standard practice, still there will be individual patients who cannot pursue these technologies because they do cost money and sometimes are not possible in certain situations. So how do we really counsel those patients regarding future fertility, contraception, hormone therapy in the future? And is there a window of opportunity where we can perform fertility preserving procedures even after initial therapies? So you've all seen this slide before. We know that women are endowed with a certain number of follicles, and over the course of their life, this number drops down. At around 50 years of age, the eggs essentially run out, and a woman stops having periods. I am particularly interested in understanding how cancer therapies affect reproductive function in women. We believe that cancer therapies essentially accelerate the process of ovarian aging by destroying ovarian follicles prematurely. And depending on the timing of the exposures, it might affect pubertal development in individuals or may cause early menopause. This accelerated ovarian aging process can lead not only to infertility, but it also can have long-term impact on a patient's bone health, sexual health, and cardiovascular health. So this is a picture that just highlights the acute ovarian toxicity caused by chemotherapeutic agents. And this is mouse data showing apoptosis of follicles after 12 to 24 hours of exposure to doxorubicin. In terms of epidemiologic data, most of the data in young cancer patients on the reproductive risks really revolves around looking at menstrual function as an outcome. And we know that patients who are exposed previously to cancer therapies are at increased risk for premature menopause, and certain exposures are more toxic than others. For example, alkylating agents and radiation therapy are particularly toxic to the ovaries. So there are problems with these studies in that they're retrospective and have inherent bias, but also they're not looking at outcomes that are of real clinical interest to us. Just because a woman's having regular menstrual function does not mean that she's fertile, and so large prospective time to pregnancy or fertility studies really don't exist in this population, are very, very difficult to conduct. There's been increasing interest in looking at surrogate measures of fertility potential, so measures of ovarian reserve like hormones and ultrasound measures that, at least in the infertile population, can give us information about whether pregnancy will occur with treatments. And so we are interested in looking at those measures in the cancer population to really understand how reproduction is affected by cancer treatments. So the aims of our studies really were not only to look at the acute changes in newly diagnosed patients over the course of treatment, but also to look at the long-term impact and changes that occur in ovarian reserve in cancer survivors. And for the acute changes, what we're really interested in is documenting kind of the insult to the ovaries and the recovery that occurs during and after treatment, and really identify predictors of recovery of ovarian reserve in the population of cancer patients. So for this aim, we've been conducting a prospective cohort study at Penn and at Children's Hospital of Philadelphia, really capturing patients before chemotherapy, and then following them every 3 months for a total of 18 months, looking at baseline characteristics and treatment parameters, and really looking at changes in measures of ovarian reserve over time. So far we have enrolled 62 subjects. On average, they're in their mid-20s, thin, primarily Caucasian. 40% have breast cancer, another 43% hematologic malignancies, and the majority have been exposed to alkylating agents. So the best way to kind of show you what's happening over time in this population is to show you, I think, a graph of a single individual, a 17-year-old with Hodgkin's lymphoma who was treated with a course of ABVD. And so you can see these very classic kind of dramatic changes in hormones that occur during therapy. So 0 is the baseline, and you can see that with the acute follicular destruction that occurs, you have decreases in anti-Müllerian hormone, which is a direct measure of ovarian function, of ovarian follicles, and estradiol. And in response to this destruction, you have an elevation in follicle-stimulating hormone. Over time, after about 100, 200 days, you see recovery of the direct measures and the indirect measures, FSH. And you can see that almost at 400 days out here, recovery is not complete. And so it'll be interesting to see how much individual subjects recover over time, depending on the therapy that was administered. When we summarize these changes over time among this population, we still, there are many patients who don't have post-treatment visits, so it can be difficult to look at this point. But nonetheless, we see that the changes are similar to those in that individual patient. There's an acute impairment of ovarian reserve initially during the treatment phase, and then a recovery afterwards. This is a graph showing multiple subjects over time, and FSH and estradiol are tricky, as you all know, because the levels do depend on whether the patient varies with hormone use, I should say. So if a patient's using hormones during that time, like the birth control pill, you really can't look at those measures with any accuracy. So this data is restricted to subjects who are not on hormones. And essentially, you see similar rise in FSH and kind of drop in estradiol, and then some degree of recovery over time. Looking at anti-Müllerian hormone and antral follicle counts tends to be better. These are better measures of ovarian reserve because they are not subject to as much variability from hormone use. However, still, the use of GnRH agonists in this population can be problematic and can make looking at these measures difficult. So we've restricted these graphs to those who are not on GnRH agonists during any time of their therapy. And so, again, you see this kind of classic drop in these direct measures of ovarian reserve, and then some resolution. We've also begun to look at whether treatments are affecting how these hormones change over time. And so here I'm showing the initial change pre-treatment to during treatment measures in the measures of ovarian reserve by alkylating agent status. And it looks like those subjects who received alkylators had a more dramatic change or impairment in the measures of ovarian reserve, at least initially. And so this is interesting when thinking about, how to look at these measures and how to really predict what's going to happen long-term with these patients and what treatments are potentially the most gonatotoxic. So at least for this aim, to summarize, we found that acute hormone changes reflect acute follicular destruction during therapy, that measures partially normalize as the new cohort of follicles emerge from the primordial follicular pool, and that we see more dramatic changes in measures of ovarian reserve with higher risk treatments like alkylating agents. And this is particularly important when testing new chemotherapeutic agents, in the short term, to develop agents that are as effective but not as deleterious to gonadal function. A larger question is, can we really predict future measures of ovarian reserve and ultimately the reproductive lifespan of an individual based on these baseline measures and their specific treatment parameters? And this, again, is important for counseling patients, not only about their future reproductive function, but also to target fertility preservation treatments. And so the second aim of the study is really looking at the longer-term picture, so what's happening long-term in cancer survivors, and really, what is the utility of these measures? Are they telling us something about time to menopause, this reproductive window, and the fertility in this population? And so for this aim, we've been following cancer survivors between the ages of 11 to 35 years who are at least 1 year out from treatment, and also recruiting similar age controls, and essentially following them annually with measures of ovarian reserve, looking again at similar measures in addition to menstrual function, capturing menopausal symptoms, and also looking at pregnancy risks and rates over time. And so far, we've enrolled 195 subjects, and we've analyzed hormone data on 138, 71 exposed, and 67 similar age unexposed subjects. The majority of these patients had a history of hematologic malignancies, but there's various other diagnoses represented, and the vast majority received alkylators. So in terms of baseline characteristics, the majority of this population, again, is in the mid-20s. They're generally normal weight, primarily Caucasian, and unmarried. When we compare the exposed to the unexposed group, we find that the exposed group is slightly more likely to be Caucasian and less likely to smoke. Looking at measures of ovarian reserve and comparing them between groups, we find that the exposed population is their measures of ovarian reserve are more impaired, so FSH levels are slightly higher, anti-Müllerian levels lower, and antral follicle counts lower than the control population. And then when we restrict the analysis to only those subjects with regular cycles, not using hormones for the previous year, we find that, again, FSH levels are higher, anti-Müllerian hormone levels lower, and antral follicle counts lower, even in these regularly menstruating subjects compared to controls. Looking at the treatment response and whether these variables really vary by treatment status, we find that FSH level is higher as the cumulative dose of alkylating agent increases in these population. And also, anti-Müllerian hormone levels are lower in those who have been exposed, to more alkylating agents. And so this alkylating agent score is really kind of a cumulative index of alkylating agent exposure. We also find that patients who were exposed to pelvic radiation have impaired measures of ovarian reserve across the board compared to those who were not exposed to radiation. And those who received radiation as part of a bone marrow transplant, but still were having regular menstrual cycles, also had significantly impaired measures of ovarian reserve compared to those who did not have a bone marrow transplant or radiation therapy. So what do these measures really tell us? We know that they're impaired in cancer survivors. we see that they are dependent on the previous treatment. But what do they tell us in terms of time to menopause, long-term reproductive outlook, and also fertility? Well, at this point, we have limited data, but we have had the opportunity to compare these measures of ovarian reserve in cancer survivors to naturally aging late reproductive women. And we found that high-risk survivors in their mid-20s who received high-dose alkylating agent therapy, their measures look very similar to women in their mid-40s who are aging naturally. So the question is, does that really give us information about when they will be going through menopause, and can we anticipate the timing of those events? With respect to fertility, there's very limited data on whether these measures reflect fertility in this population, but during this study, there have been a number of subjects who've actually conceived. 14 cancer survivors and 11 control subjects conceived during this study. And we found that overall, AMH levels in the survivors who conceived were lower than those in the control population who conceived. But what was more interesting was the fact that survivors who conceived had a vast their measures of ovarian reserve were very variable. So there were survivors who had extremely poor ovarian reserve who still got pregnant. And we observed that, and I think that really gives us information about the fact that these measures may be telling us more about the quantity of eggs remaining in the ovaries rather than the actual quality of the eggs. In order to get a little more information about what the reproductive horizon is for these cancer patients, we're also looking at changes in measures of ovarian reserve over time in the population. And these graphs represent slopes of hormone levels over time in the survivors. These are the exposed and the unexposed subjects. And basically, you can see that while the slopes are not significantly different between the groups, the rise in FSH appears slightly slower in the exposed population compared to the unexposed population with respect to FSH. And again, AMH seems to be going down slightly at less of a steep curve in the exposed versus the unexposed population. And so this is very preliminary data, but it may be useful in terms of using these hormones to really help to predict when menopause is expected to occur in this population. So the preliminary findings from the second aim is really that measures of ovarian reserve are impaired in cancer survivors in a dose-dependent fashion. We found that mid-reproductive age survivors have measures of ovarian reserve that are similar to those of late reproductive age women, and that hormones may actually change more slowly over time in survivors compared to controls. But it's not clear yet whether these measures actually predict fertility or time to menopause in this population. So we've launched a larger study not only to assess the acute changes in reproductive functioning, but also to look at these long-term changes that are occurring in measures of ovarian reserve. And also we're looking at urinary hormone studies to assess kind of what's going on in the follicular and luteal phases in this population of patients compared to naturally aging women. So I wanted to shift gears a little bit and talk about kind of where we have been and what we have accomplished at Penn in terms of oncofertility, and also talk a little bit about the collaborations that have been made throughout this consortium. So the vision of the consortium was really to bring technologies from the bench to the bedside and really expand options for fertility preservation in cancer patients. And I think that the consortium has had a tremendous impact on clinical care because it's really helped to spearhead oncofertility clinical programs and research across the country. And we have seen this happen at our institution, and really it's been quite dramatic to watch the progress that's been made. The NPC put forth a model. How should you start an oncofertility program, what you need to do. Not only do you need to set up clinical services, but you have to have a dedicated team, You need to go out there, you need to educate, you need to make these technologies available to patients and providers out there. And so we have done that at Penn, I wanted to go through some of our numbers, at least from the past 3+ years as part of this consortium. So basically at Penn, I personally have seen over 150 recently diagnosed female patients between the ages of 8 to 48. Primarily these patients have had breast cancer or hematologic malignancies. Another large group consists of patients with gynecologic cancers, but there are a variety of different diagnoses represented, including even medical diagnoses for which patients are getting cancer treatments. Overall, a third of patients come talk to me and decide not to pursue any fertility preservation technologies. About a third pursue IVF with embryo banking. 10% have chosen to bank eggs, and 13% ovarian tissue. I've also been performing more and more ovarian transposition and PEXI procedures as this program has moved forward, and some patients have elected to receive GnRH agonists. I've also been taking care of a lot of cancer survivors, not only through the program, my research program, but also for clinical care, gynecologic care for these patients, counseling regarding hormone replacement therapy, and actually taking care of them after cancer therapy once they decide they want to have children and they actually didn't do anything to preserve their fertility beforehand. So that is an interesting group as well. In terms of ovarian stimulation, we have performed 53 ovarian stimulation cycles at Penn. The majority of patients have been Caucasian, nulliparous, and 75% have actually had a partner. The majority have consisted of breast, hematologic, and gynecologic malignancies, as I mentioned, kind of reflecting the overall cohort that I'm seeing. But 30% have actually had previous treatment. So overall, in terms of the numbers that we've actually gotten from the stimulation cycles, we've had about 12 oocytes retrieved on average in these cycles. And overall, we've cryopreserved 7 embryos or mature oocytes in these stimulation cycles. But the range has been pretty broad, anything from 0 to 19, as you can see. Only 4 subjects at this point have come back and thawed embryos, while we have had pregnancy from oocyte cryopreservation. It wasn't a cancer patient, so we can't really talk about that. But anyway, 4 of the cancer patients have come back and actually thawed the embryos. 2 actually used gestational carriers. And we've had 4 live births. 1 was a set of twins and 1 ongoing pregnancy. So basically 100% success rate, which is absolutely exciting, even though the numbers are very small. And these are some pictures of success stories. This is kind of the most interesting one to me because this baby was actually born in a cancer survivor who was 46 years of age, at the time of delivery actually 47, breast cancer survivor who was completely menopausal. And she was unable to pay for an egg donation cycle, so decided to join our donor embryo program and had a baby recently. And so I think that's just amazing and speaks to the fact that there are lots of different ways to have a family, and taking care of these patients post-treatment can be incredibly rewarding. The other couple that I think is kind of an interesting story is this couple. She has a horrible family history of breast cancer and a BRCA mutation. She came to me in her mid-20s, married, froze embryos, and then came back a few years later and decided that she wanted her sister, who was BRCA negative, to actually carry the pregnancy. And so this is her sister here. She carried the pregnancy and delivered twins without any complications. So that's great. The other thing that I wanted to mention was our ovarian tissue cryopreservation experience, which has been pretty vast, I think, considering, where we are. We have frozen tissue on 19 patients, and we're doing this not only at the adult hospital, but in the Children's Hospital of Philadelphia as well. 9 were adults, 10 children, and I have another case actually Thursday of this week. And the age of these patients have ranged anywhere from 8 years old to 36, and a variety of different diagnoses are represented. No patient has come back to use the tissue yet, so we've not done any transplants at this point. We've also been collaborating with Jill Ginsburg and Ralph Brinster, cryopreserving testicular tissue in prepubertal boys, and that was really spearheaded by some data that he had showing that autotransplantation of spermatogonial sperm cells resulted in live birth in mice. So that is a really exciting experimental protocol that we're offering, and again, it's only been through collaboration and working with oncologists, particularly in pediatrics, that this has been possible. We've also, I wanted to highlight some collaborative research that we've done as well. One of the most exciting collaborative projects I think that we've been involved in has been with Thomas McDade here at Northwestern, where we have done work validating an AMH blood spot assay. We collected 78 match samples, blood and blood spot, and then sent them to Tom, who then did the assays showing that there was a very high correlation between serum and blood spot AMH values, and this really has a lot of implications in terms of doing large epidemiologic studies of ovarian reserve in the general population, but also in cancer patients. We've also worked closely with Jennifer Mercereau at UNC, and are hopefully publishing this paper soon, looking at predictors of fertility preservation in breast cancer patients, and we found that several factors do seem to be associated with whether a breast cancer patient pursues fertility preservation or not, including early stage and lack of neoadjuvant chemotherapy use. And then we've also been collaborating with UNC, pooling our data, clinical data, in the area of hematologic malignancies. I think this is a particularly interesting group of patients to work with, particularly leukemics, who often are very ill when they present and need immediate treatment. And so treating them and offering fertility preservation can be quite tricky. Overall, we've seen 67 patients with hematologic malignancies for fertility preservation consults, and of those, 39% actually did pursue fertility preservation of some sort. The ones who actually elected or tried to undergo ovarian stimulation are these 19 subjects, and interestingly, almost half of them actually, well, more than half of them actually had already seen previous chemotherapy at some point. And so even though the ovarian reserve seemed to be diminished in this population post-therapy, and they required more total gonadotropins for stimulation, still the majority of them did pretty well, which is nice, and we got comparable numbers of eggs and embryos to freeze. And I think that has implications on really talking to patients and offering them an option for fertility preservation after initial cancer therapy. Potentially there's a window at the time of relapse, for example, if they're going to get a bone marrow transplant. I've also collaborated with Jennifer Levine, and we put together a grant and got funding through the Leukemia Lymphoma Society, where we're launching a multi-center study of ovarian reserve in pediatric lymphoma patients. So that's a really exciting project. And so, you know, I think that over the past 5 years, we've seen really dramatic improvements in clinical care and also research initiatives, and that has been largely in thanks to this program, which if I weren't part of, I might not be doing all this stuff, which is very exciting. And I think we're really gaining a better understanding of the impact of cancer therapies on reproduction. We've improved awareness and access to fertility preservation services for patients across the country, and I think that we're doing a lot of great work improving the technologies that are out there. So hopefully this work will continue, and I have been really excited to be a part of it. And I wanted to thank my funding from the NIH particularly, who've been very generous, my collaborators at CHOP and the Abraham Cancer Center, and throughout the NPC. And also I wanted to say a special thanks to Lance Armstrong Foundation and Fertile Hope for providing financial assistance to our patients, which has been absolutely huge. Thank you.
Thank you, Clarissa. You've been an absolute model for what a clinical investigator who's very activist can do, and together with several of the other folks in the audience, Jenny Mercereau and others in the MPC, really have done an extraordinary job of pushing the envelope in this area very quickly, and that's really exciting to hear. I should also mention that out on the on the table are some of the pocket guides that Clarissa was the lead clinical writer for the Hormone Foundation Oncofertility Consortium patient guides and pocket guides. I hope you've all downloaded it onto your smartphone by now for Save My Fertility. And these are really awesome. What you've done is really disseminate your knowledge, as you nicely described here, into practical guidelines. And so I think that translation will be very long-lasting, and that's just superb. Do we have questions for Clarissa on her scientific progress?
I just have a question about the costs when you're doing the tissue cryopreservation, those surgeries. Do you have any idea what the average range is of cost for the patients on those?
Yeah, I did not get into that in detail. We could probably talk about these things all day. But we actually, it's been interesting to follow what's been going on, because initially when we started, we were very reluctant to charge patients for the procedures at all. And we still are. Their IRB, we were one of the first programs that started this whole process, and so our IRB process was a little different than others, and we were very reluctant to even put any cost. So essentially we were given funds by a donor, and we established these funds to potentially pay for the procedures. But having said that, we really haven't had to use much of the funding, because usually we couple the cases with another surgery. So for example, the cancer case that I'm doing on Thursday, she's getting a port placed, I'm running over there, doing laparoscopy, taking a piece of ovary out. And it's hard to know. We need to go back and figure out what's billed, what's not billed, how exactly is that happening, but really our account not much has hit our account. We have a setup where we are only charging research costs for the procedures, so we have a cost of $3,000 built in for the procedure, including anesthesia and everything. So that is the research cost. But I've heard that some institutions, they charge much more for the clinical care piece of it. But I think that I think there needs to be work in that area to figure out what is the actual cost, what are insurance companies willing to pay, how does that work? And I think that's a little nebulous at this point, because it's not become standard that it's done all the time, and I'm not sure it's on the insurance company's radar all the time.
Yeah, thanks.
Can't be more vague than that, anyway.
Well, thanks, Clarissa. I'm Kat Lynn from UW, and we just are getting our program started. And Oncofertility is pretty active there with the Cancer Care Center around Puget Sound. But I've been really impressed with how within the field of oncology that there are varying degrees of interest for patients to pursue fertility preservation. And one group that's been particularly staunch, at least in our area, of kind of dissuading patients from fertility preservation have been the hematology oncologists. So I was amazed to see how many patients have come through. And you're right, they're very sick. So can you tell us how that's worked out? Because oftentimes the patients can't wait.
Right. So what happens is, because I'm doing studies in this area too, we try and have our feelers out to figure out who's on the floor, who's on the floor. Leukemics pretty much get admitted to the floor, and then you usually can talk to them at that time to discuss fertility preservation options. Almost uniformly, when you have an acute leukemic who's admitted, you are not going to be able to do anything right then and there. So the conversation that we have is about, okay, if you only get these drugs now, actually your risk, they are usually not that gonadotoxic. It's the ones who actually have to go to transplant that are the most problematic. And those patients have a very, very high risk of permanent ovarian failure. So if there's a window between the time of initial treatment to the time of transplant, I try to see them back in the office, and we have stimulated patients then, or they might elect to do ovarian tissue cryopreservation because their ovaries don't respond or they're not good candidates, all of
So those patients have had one course of chemotherapy already by the time they get to see you before they get their consolidation treatment, right? So, and the yields that you're seeing, 7 or 8 embryos for those patients are really,
Some of those are lymphoma patients who've relapsed, and those patients don't, usually there's a bigger window where their cancer, you have a lymphoma, they found it, okay, now you can go ahead and stimulate them, and they actually respond the best. The acute leukemia, there's not much data in the acute leukemics who come back, but we've had a few patients have come back and done that, and we have had embryos to freeze.
Thank you.
So that needs there needs to be a lot more work in that area.
Jenny?
Hey, Clarissa. I'm Jenny Mercer at UNC. I was just wondering, I was curious to see how many of your ovarian tissue cryo patients were actually biopsy specimens rather than whole ovary.
That's a good
and I was
question.
wondering if you could...
The majority were actually biopsies because, again, all of the CHOP patients were actually biopsies because that's one of the stipulations by the IRB. So we felt uncomfortable also taking an entire ovary on a child, and it really, we just don't know how much ovarian tissue should we be taking, what kind of impact it's going to have on their long-term ovarian reserve if we take an entire ovary versus not. But basically, the IRB at this point is written for biopsy only. It took us 2 years to get our IRB through at CHOP, so basically, it's very conservative. High-risk kids, initially the age was limited to over 11. Now the age range has been expanded, but it was high-risk kids, biopsy only, had to be combined with another procedure if they were between 11 to 13 years of age. There are lots of little stipulations. In adults, it's more lenient, but again, depending on the clinical situation, biopsy versus taking an entire ovary out, I would talk to the patient about it. But again, a lot of them have been biopsy cases.
And can you briefly comment on the technique that you're doing for the biopsy? Are you doing a cortical?
Yeah, laparoscopic, same as what these guys show. So we'll probably talk about that with the NPC more. Okay.
Sanaif Sahar from the University of Michigan. Clarissa, this is a great presentation as always. Can you comment about how you counsel patients who've already received a single or 2 doses of chemotherapy during a time of ovarian stimulation about the impact of chemo on gonadotoxicity and the quality of embryos and what it means?
There's limited data in mice to suggest that chemotherapeutic agents may be causing DNA damage, increases miscarriage. We do not know really the effect. I don't recommend stimulation during chemo. It's also usually very difficult to stimulate these patients. Their ovaries just won't respond. So typically, I recommend a window of at least 3 to 6 months based on no data.
3 to 6 months of washout
from
period?
the time of exposure.
Okay, so I think there was a comment earlier. If you have a person who's received a single dose, think of like a transplant patient who receives pre-transplant chemo. So those patients you won't stimulate while...
It depends how much time we have.
Okay.
Sometimes there's a lot of time between the time of initial treatment
Chemo
and actually
transplant.
the time they come for transplant because they need to get
So kind of
matched
3 to
and
6 months is your window?
Ideally,
Okay.
I have stimulated patients if they understand that we don't know what effect it has on their eggs or embryos. That's the thing. I know that I did a presentation with Nicole Noyes at ASRM, and she has actually had patients respond during stimulation and has had a few cases where they have done frozen eggs or embryos on those patients. Again, there has been no pregnancy reported in that population, so we do not know. And that is an area that needs to be looked at more.
Awesome, thank you.
Yeah.
Hi, Carissa. Nice talk. Thanks so much. Mike Bursaw-Barg, I'm the second person from the Michigan contingency here. Can you comment on efficacy of ufurpexy, of GRNH antagonists, and what is your technique for ufurpexy?
It depends on the situation. I usually meet with the radiation oncologist, and depending on the situation, exactly where the radiation, what dose of radiation they're getting, we talk about placement of ovaries. So it totally depends. We can talk about it after if you want.
She's available for consult.
Efficacy?
And again, the data, depending on what you're doing, there's some data on the efficacy of ufurpexy and ovarian transposition. Some of the data is very tenuous. So we can talk about that as well.
Great, thank you.
Yeah.
Clarissa, thank you so much. What a terrific presentation.